Hey everybody, welcome back to another live stream from Synapse Care Solutions. This month we are focusing on neonatal stress, pain, and the brain. So I hope that you have been following along and that you keep an eye out for the sessions that are to come. I'm Kathy Randall, and it is my pleasure to introduce today's live stream speaker. It is Dr. Danilyn Angeles. She was my original NICU educator, amazing mentor about all things baby brain, and she went from being the educator to the manager to being a PhD bench scientist and trying to understand everything that has to do with physiology around baby brains and pain. So she's going to share with you not only her bench data, but also her clinical research data. And this is kind of heavy on physiology in the beginning. She dives into how pain and stress really tax the baby's metabolic system and why it's so costly for them to experience pain and stress. She then goes into some clinical data where she looked at the NIRS data and then stress markers in the urine and the blood. And then she also shows all of that together. So she shows the baby's case as well as NIRS data and her biomarkers. So super interesting physiology. And then she talks about all of her research she's done on sweet solutions and whether or not they really actually help reduce pain and stress in our babies. So this is a jam-packed lecture. It's from our One conference in 2021. The other thing I forgot to mention is that Danilyn was our first winner of the One Nurse Award from our One conference back in 2017. So she is a very special individual. She is a gifted scientist and teacher. I hope that you truly enjoy this presentation. If you'd like to get her slides and some of the resources that she mentions in this presentation, go ahead and either scan the QR code right here on this screen or click the show notes below. If you want to see more videos like this from us, tell YouTube that you like it by hitting the subscribe button below. It really helps our channel and it helps YouTube know to send you more videos like this. So without further ado, please, I am so excited to introduce Dr. Danilyn Angeles.
So I am so happy and honored to introduce our next speaker, Dr. Danilyn Angeles, and I already got permission to go off script, so I'm going to. Dr. Danilyn Angeles is going to be presenting an update on pain management in the NICU for us. This has been an area of her research for quite a while now, her and her team, but I do want just to say that Dr. Angeles was my very first boss in the NICU at Loma Linda, and I was one of, I think, 350 nurses, so I don't even know if she would remember me. But what I remember the most is my very first lecture on the pathophysiology of IVH that she presented to the staff at Loma Linda, and I think she was still our manager at that time, and I was just like, oh my God, where have I landed that I'm so lucky and privileged to work under this woman? Just like Kathy, she was such a valuable resource to us and always kind and the kind of manager that you want to work under. Also, we cannot neglect to mention that she was the very first One Nurse Award winner from the One Conference. So we're very fortunate, and you guys are going to be so happy to hear her speak today. So go ahead and take it away, Danilyn.
Thank you, Sharon and Kathy. I'm just so touched. I feel like I have birthed two wonderful nurses. When I hear you guys, I'm so thankful to be part of your growth. I'm just very impressed with you all, with both of you, and what you've done to change the way care is delivered to our babies. I was just speaking during our breakout that each nurse really needs to know how important their role is. They're not just there to perform tasks. We used to think, oh, if I'm able to do all my tasks for my shift, I'm a good nurse. If my bedside looks clean, my baby looks clean, I'm a great nurse. If I leave tasks not done, I'm a bad nurse. Cannot be like that. We are so much more important than that. And that's what I'd like to show you some data. It's funny because I listened to all the different topics, and my data will support the data that was shown, that was talked about earlier. So I want to show you some preliminary data that I haven't published yet, and also a little bit of physiology. As you all know, I love physiology, so you have to give me just a few minutes to talk about what the role of physiology in all of this. So we'll talk about cerebral and renal hypoxemia and the effect of procedural pain. There's several learning objectives that we will go over. There's 2 negative consequences of neonatal pain. At least you need to describe at least 2 negative consequences of neonatal pain. You should be able to discuss one recent research finding and describe the relationship between NICU procedures and cerebral energy metabolism. And you should be able to list 2 or more strategies to manage neonatal pain. So those are my learning objectives. So just some definition. What is hypoxemia? When we think about hypoxemia, this is very different from hypoxia. Okay, hypoxia means decreased PaO2. So that is something you get from a blood gas, for example, or from a TC monitor. So when you see low PaO2, that is hypoxemia. When you look at your pulse ox and your SpO2, that is hypoxemia. That just means there's not enough oxygen in blood. Okay, PaO2 means a low PaO2 means not enough oxygen in blood. When you see a low pulse ox value, 85%, that means that only 85% of hemoglobin is bound to oxygen. All right, so there's less saturation. The hemoglobins are less saturated with blood. So that's what that means. Hypoxemia means not enough oxygen dissolved in blood. SpO2 means not enough oxygen bound to hemoglobin. So that's hypoxemia. That's different from hypoxia. Hypoxia means there's not enough oxygen inside the cell. So that is really where damage can occur. All right. Obviously, when there's hypoxemia, you can have hypoxia, right? What we can measure in the unit, in our blood gases, in our pulse ox machines, is hypoxemia, but we really cannot measure hypoxia yet. And that is where my laboratory is able to came in, and I was fortunate to collaborate with several biochemists who know about how to measure hypoxia. So if you remember from a long time ago, when there's hypoxia, I'm going to start writing here. What will happen is, first of all, before I go there, just to remind you that the reason why we need oxygen and glucose is to make ATP, right? This is the energy currency of the cell. This is just like the dollar is the currency of the United States, ATP is the currency of the cell. If there's hypoxia, what will happen is there will be enough, that means there's not enough oxygen in the blood. It will cause ATP to degrade to something called ADP, to AMP, and then adenosine. And this adenosine will degrade into multiple things like hypoxanthine, xanthine, and uric acid. So my lab basically measures these markers right here, which you can only see if there's hypoxia. All right. So my lab does not just measure whether there's decreased oxygen in blood, but my laboratory can measure whether there's decreased oxygen inside the cell through the measurement of these markers. Okay, hypoxanthine, xanthine, uric acid. So that's just definition. How about ischemia? Ischemia means there's not enough blood flow to the tissues, okay? And asphyxia means there's low PO2, decreased PO2, increased PCO2. So when you have both high CO2 and low PO2, it's called asphyxia. So those are just some terms that we use constantly that we need to just to clarify things. Now I will talk about hypoxemia today, and then I will also talk a little bit about hypoxia. So now let's talk about pain. How does that relate to pain? There's multiple references, and I have it at the end of this talk, that when that pain-related stress, because the baby can't really differentiate between pain and stress, okay? Pain-related stress can have effect on brain growth. For example, it decreases cortical thickness. It decreases development of these somatosensory regions, and I'll show you some examples of that. It will delay language skills, decreases IQ at school age, alters pain sensitivity. So that's very clear, the effects of pain on the central nervous system. So the question will be, since I'm a hypoxia kind of person, right? So my question will be, how does the brain use oxygen? Why suddenly why do we have hypoxia now? So I gave you a little bit of review here. This is a classic physiology textbook, all right, that you can find in the library. This is actually the textbook I have my students buy, which I don't know if they ever use it. I think they use it as a door stopper or something. It's really thick. Anyway, so it says here, if you just look at this, it says here, under resting conditions, Brain metabolism, which talks about how much ATP is used by the brain, accounts for 15% of total ATP use, even though the brain mass is only 2%. So the brain mass only consists of 2% of the body, but it uses 15% of the ATP, of total ATP, right? And then it tells there, this other thing says, but during high levels of brain activity, metabolism or use of ATP rises by 100% to 150%. Just right there, it tells you that in adults, this is fine. We have plenty of ATP in adults, right? All of us have lots of energy reserves. But here it tells you that when there's high levels of brain activity in our premature baby, it will increase the use of ATP in our premature baby by 100% to 150%. Our babies do not have a lot of ATP, which you can easily bring them to a state of hypoxia. So the question is, what are these high levels of brain activity that can increase brain ATP use by 100%, 150%? So just a little bit, but these are my other physiology slide that I drew. So let's talk about pain. So how does the pain signaling pathway use ATP? So here it is. If you look at the skin cells, let's say these are the skin cells at the heel, right? Now, when we damage the heel, so this is the damage right here. Let's make that red, okay? When you damage the heel, there are molecules that are released. One of them is glutamate, okay? In the heel, you have these fibers, these sensory fibers, C fiber, A delta fiber. These are your, what we call nociceptor. These are fibers that these are the pain path fibers, essentially, all right? And what happens is when glutamate is released, it will bind to these fibers, all right? And it will cause ion channels to open. So if you notice here, when glutamate binds to its receptor right here, the next step will be the entry of sodium into the nerve fiber. And once sodium enters, calcium follows. And you go, okay, so what does ATP have to do with this? Okay, but that's the next step. What happens is when sodium enters the cell, usually the voltage inside a resting cell is around, let's say, minus 90 or minus 75 millivolts. That is the voltage within that nerve fiber. When sodium enters, it has a positive charge. And when calcium enters, it also has a positive charge. It will cause this membrane, this sensory fiber, to called depolarize, okay? Which makes the cell, which means that the cell became more positive. It used to be minus 75, now it's plus 20 millivolt. That's called a depolarization. And that is what sets off this action potential, all right? This action potential just means that the cell now has sodium inside and calcium inside, and that generates an increase positive voltage that's then transmitted. So here we are. So this is the heel, for example. So that action potential is transmitted to the dorsal root ganglion, to the spinal cord, crosses over to the other side, goes up to the brain, to the thalamus, to the somatosensory cortex. And you go, where is ATP being used here? Because the whole thing is about ATP. What happens is, let me just erase all of this. What happens is this sodium that enters and calcium that enters, okay, you cannot leave those ions inside the cell. Those ions have to be removed out of the cell because the sodium inside needs to be low. So what causes the sodium to be moved out of the cell, I call the sodium. But why are they called sodium potassium ATPase? Because these pumps use ATP, okay? So every time you depolarize or sensitize a pain receptor, pain fiber, and which causes sodium and calcium to enter that nerve ending, the sodium potassium pump has to work hard to kick that sodium that was inside the membrane out. That causes ATP, a lot of ATP. So there's ATP used at this level. Okay, there's ATP used when there's a synapse here at the spinal cord. When this is second order neuron synapse at this area, there's ATP use. when that signal is relayed to the cortex, the different parts of the cortex, there's lots of ATP used. And then notice that there's also connections to different parts of the brain, ATP is used. So all those connections use ATP. And there's data that shows that when we move, when we touch our skin, that also causes an action potential, right? And you're correct, it will cause action potentials as that touch or mechanical pressure goes to the brain. However, it's been shown that the action potentials that are used, that are generated, ATP utilized, is 10 times more with painful stimulus. Okay, 10 times more response. So this is where high levels of brain activity, this is talking about a big example of high levels of brain activity, brain stimulation. So this is why this is how there is a relationship between nociception or pain stimulation and ATP utilization. And again, our baby's brain does not have a lot of ATP, okay? And if we are constantly barraging, there's data that says up to what? At least 7 to 12, sometimes up to 35 painful procedures. That's just the painful procedures per day on our babies. Every single time that happens, we are using up this energy currency and increasing the amount of ATP used by our brain. So I have all kinds of stuff in here that I want to show you, but anyways, let's go to the meat of this. The higher the pain stimulus, the higher the frequency of action potentials. Again, action potentials use ATP. Right? So this is about, and when you don't have enough ATP, that's called hypoxia. Right? And that is what's causing the cell injury. So I have all kinds of stuff in here for you, but I love pictures, and maybe we'll go back to this if you have questions about it. This is showing you the sodium channels, all right? So notice if you get your blood drawn, and you see this in the babies, when we get our baby's blood, we notice that sodium is 145 and potassium is 4. That's what's in blood, right? This is in blood. Inside the cell, this is inside the cell, sodium is 12 and potassium is 150, right? So which is why when glutamate binds to its receptor, it opens a sodium channel, which makes it so easy for these high levels of sodium outside to go inside. Because there's so much more sodium outside, it will cause this sodium to go inside the cell. And what will happen is if there's too much sodium inside the cell, you don't want that, right? Oops, you don't want the sodium to be inside the cell. So the sodium potassium pump will then cause the sodium to be removed through the sodium potassium pump. And that's what causes utilized ATP. And it shows you here, what are the effects of hypoxemia? Notice that it causes the glucose levels in the brain to go down. Okay, so there's a lot of glucose levels in the brain go down when there's hypoxemia. ATP levels go down when there's hypoxemia. See, the ATP levels go down. And I said one of the byproduct of ATP breakdown is adenosine. Adenosine is a vasodilator. So we talk about how we want to prevent increased cerebral blood flow, right? Now, if we are constantly utilizing ATP because of the pain pathway being utilized and an action potential is ongoing, you will produce adenosine, which will vasodilate blood vessels in the brain and can increase cerebral blood flow, right? So not only do you have hypoxia with drops in ATP, the byproduct of ATP breakdown because of hypoxia is vasodilation, which can increase cerebral blood flow. With our babies, when we expose our babies to procedures and pain, we see an increase in heart rate. Now you go, okay, increase in heart rate. We know that the normal is 120 to 160 of heart rate, right? Now, what does that have to do with hypoxia or ischemia? One thing, I don't know if you've seen this when you were in school, but when someone, for example, shine a light in the eyes, the occipital cortex is the one that detects the light, right? And there's significant increase in blood flow to the occipital cortex because of the light. which tells you that there's a big response, that blood goes to where it's needed, right? However, so what that means is that if there is an increase in ATP use in those ATP, in those pain pathways, so these pain pathways, if there's a lot of ATP being used here, okay, these are the pain pathways. If there's a lot of ATP being used here, these areas, blood flow should go to these areas. But the problem is when we have painful procedures, our heart rate, the baby's heart rates go up. Now, what does that have to do with anything? No, our baby's heart. So this has to do with cardiac now, okay? So our baby's hearts, the ventricle, the left ventricle is small, right? Cardiac output, which is the amount of blood that is ejected per minute, okay, is related to heart rate and stroke volume, okay? So this is the amount of blood ejected per minute. If the heart rate of our babies go up, okay, what will happen is that should increase cardiac output, correct? But the problem is when the heart rate of our babies go up, it will decrease the amount of time, because the heart is going so fast, it decreases diastole, okay, which is the time it's needed to fill the ventricle with blood. So this will decrease diastolic filling. So diastole is not just a time for resting where the heart is just resting, it is actually a time for filling. If the heart is beating so fast, the ventricle will not fill. So that really what happens with our babies, and stroke volume is the amount of blood ejected per beat. Because filling time drops, stroke volume will also drop with our heart, with our baby's heart. So that what will happen is cardiac output will drop, and this is where you will have ischemia. Okay, so it's different with our babies because the ventricle of our babies cannot really expand, and the baby's compliance of the ventricle is not, is the baby's left ventricle is stiff. Okay, so the ventricle cannot just expand and fill. In addition, when our baby's heart is beating so fast, the diastolic phase, the phase of diastole, remember there's systole and diastole. Systole is when the baby ejects blood to the aorta, the left ventricle ejects, but diastole is when the left ventricle fills. When heart rate is fast, this part drops, okay? The diastole drops. The left ventricle is not enough of blood. There will be decreased cardiac output, and there will be ischemia. So at a time when more blood flow is needed, because we're using a lot of ATP, because we are stimulating the baby either through our handling, through our painful procedures, the blood flow is not there, all right? So this is a little bit of kind of physiology. We published the relationship between pain and hypoxia in 2012. And here we looked at tape removal. And what we saw is this tape removal increased these markers. We saw the increase in basically babies with no tape removal, the uric acid levels is here. Babies with tape removal, the uric acid levels there. And then this is actually a stress marker. Those with tape removal have higher levels of MDA compared to those with no tape removal. So this shows you that something as simple as tape removal can significantly can cause hypoxia by increasing plasma markers of hypoxia like uric acid and MDA. So now back to some preliminary data. So this is based on drawing blood from A lines, or we did not remove plasma and cause pain. The babies in this study all had lines, so we drew blood half an hour after tape removal to measure. Well, we do baseline blood with tape removal, and this tape removal is clinically required. Then half an hour later, we drew blood again from the line. So these all biochemical. There is a new, all of you are familiar with NIRS, hopefully. Now, what we did next is we connected babies, and we want to know the effect of common NICU procedures, O2 saturation. And what I thought is very interesting, so this is percent change from baseline. And notice that in this common NICU procedure, I'm looking at, if you look at this, diaper change, auscultation, HELAN, PICC line, cerebral assessment, notice that On some babies, on some of them, there's hardly any change, like a 5% drop. But there are some babies where common NICU procedures cost 10% drop up to 25% drop of regional O2 saturation, even a 35% drop. Notice here, right here. And so I go, okay, we have two probes. We looked at the cerebral StO2 and the renal StO2. And with the cerebral StO2, again, these are procedures. Notice that on many of them, there's a 5% drop in their cerebral regional O2 saturation. But then some babies have like 5 to 12%, even a baby with 20% drop. And this is not common. The renal StO2, the renal NIRS, is even worse. So there's many procedures where there's a 0 to 5% drop, but then there's some procedures that go 5 to 10%, and then there's some that are like up to 35% drop in renal StO2. So these are just regular handling procedures, and there are some painful procedures here too. So I looked and see, I just decided to look at what about diaper change. And diaper change here, notice that the majority of them, 5% to 0%. There's either no change or there's a 5% drop. But then there's some of the babies where the diaper change dropped the cerebral StO2 by 20%. And on the renal StO2, notice that same kind of thing, from 5%, there's babies that have change in renal StO2 up to 35%, but the majority, there's 0 to 5% change. So the question is, why is it that the diaper change causing this on some babies and some not? Here's one thing that when we report data for research, we always look for the average. This is the average response, but then our babies, this is not the average response. So what happens if this baby does not have the average response? How do you treat that baby? We're always looking for the average response when in fact we talk about individualized, personalized care. That is opposite the average response, right? But that's what reported in literature. The average plus minus standard deviation, where in fact we have babies who are not in the average. So what's going on here? I have 11 babies in this pilot for diaper change. So most of them, and most of the babies, the diaper change caused minimal change, 5%. But then this baby 11% change. This baby number 5, almost 15% change in cerebral. This is cerebral StO2. Again, talking about how our job when we handle these babies really make a big impact. On the renal StO2, this baby number 7, 35% change. So I was going to ask you, I'm glad that this is a workshop to get your input as to why is it. And you know this, you care for these babies. I cared for these babies. I was in the NICU for 20 years. You know that some babies just do really well, but there are some babies who deteriorate, right? Like this. So there has to be a way for us to know who they are right at the beginning of the shift and to change our care, knowing the kind of babies, who these babies are. Okay. Sectioning. Okay, this sectioning, usually there are some babies, the cerebral StO2 drop by 10%. And then I just got tired of putting the circles. Again, in renal StO2 could be up to 15% drop. Auscultation. So I'm wondering, why does auscultation have an effect? Look at the auscultation effect on renal StO2. This is just listening to the breath sounds. And I have a feeling it has to be more than that. I was just at the NICU the other day. This doctor came in and I was looking at the baby and just came in, just opened the blanket. And sure enough, what happens to the baby's heart rate starts going up from 130 to 160, 170. Again, what happens when heart rate is high? Cardiac output can drop because the heart does not have time to fill during diastole. So this is somebody who just not even paying attention, came in, just unwrapped the baby, and this may have to do with why auscultation is causing this effect. This is a normal, something we have to do, but there's got to be a way for us to notice this and change the way we care, we touch these babies. Orgastic tube placement. Okay, this is 7%, 12% change. Heel lens. Okay, heel lens, We only have several babies with HeLens here. Again, changes also 8%, 10%. And now this is very surprising to me that even getting blood pressure measurement using cuff, this is cerebral, 12%. And I go, why is it that getting by cuff drop cerebral STO2 by 12%? I don't, many of you have gotten blood pressure checked on the arm, know how painful that is. Do we even know how painful it is to the baby? I know it's painful. I cringe every time someone takes my pressure, my blood pressure using cuff. Repositioning. I know that we love to reposition. Look at there is repositioning changes cerebral STO2. And look at this is my almost 25% in renal S repositioning. So these are not even your less than 1500 gram baby. These are 30 to 32 week babies. Okay. I can only imagine. I'm going to do my next step is looking at to see the difference in the effect on the smaller babies. My hypothesis is going to be probably even bigger effect in drops in saturation. So we looked and see how what is happening to these babies over a 12-hour period. And I think I showed this in the previous one conference. And I showed, I think, baby number 4. This is baby number 1. And notice that here there's the baby's crying. And then we did some handling. 10 minutes later, we did diaper change 10 minutes later. And notice how you do have a trend towards a drop in cerebral O2 saturation. And then the same thing here, we have lots of there's suctioning, there's diaper change, OGT placement. Notice that you have a noticeable drop in renal O2 sat. After this is mesenteric O2 saturation. There's a drop in mesenteric O2 saturation, and the drop is sustained. All right. This is why I'm glad to hear that we are going away from cluster care every 3 hours, that we're going to every 6 hours, because the clustering of care, I think, when we are doing one procedure after another, so this assessment, we measure the markers of hypoxia. In here, we're able to gather urine. And we saw that after this effect right here, we have an increase in uric acid, an increase in xanthine, an increase in hypoxanthine levels. So these are markers of hypoxia that went up after this multiple, I guess this is called cluster care. Let's look what happens, assessment on handling infection. This is what we do in cluster. And it causes a sustained drop here, at least on the mesenteric O2 saturation. So that is ID baby number 1. And then number 2, this is baby number 2. Again, we did a lot of cluster care, handling, heel stick. And in this one, there's suction, adjustment of nasal cannula. We did kangaroo care and diaper change. And you go, okay, that's exactly what we did. But notice it's consistent. There's no rest and there's multiple. This is just 12-hour period right here. And again, we saw this increase in uric acid and an increase in hypoxanthine. It's a marker. So saying us that this baby is using more energy than usual. It's breaking down ATP. This one is number 3. And notice that, again, the blue here is the cerebral. You have this drop in cerebral O2 with handling. And then we have another handling and heel stick. You have sustained cerebral STO2 drops. Then you have a suction. We check the blood pressure with the cuff. Again, you have a change in cerebral STO2. We replace nasal trunks, PICC line placement. The problem here is the renal STO2 I showed in here. What happens with PICC line placement? I blew that up. And it is the renal STO2 that caused the most. This one is interesting. The NIRS data showed a lot of reductions also in renal. There's only one small drop in the cerebral STO2 and this cerebral STO2. And notice that the uric acid, there's no significant change. It did not go up. See, it's down, down, down. So we have to see what is it about this baby that caused the hypoxia markers to drop. So these all like, I'm looking at this data and I'm trying to understand this data, all right? Because again, we are, as I was speaking to Jill, I believe, in Tess in my breakout, we have to re-engineer, we have to change the way we deliver care to minimize the utilization of those sensory pathways, the use of those sensory pathways that uses ATP. Now, this is the next baby, number 5. Again, we have lots of cluster: diaper change, feeding, nasal suction. Notice how the cerebral SCO2 dropped right there. Heel stick, it's the renal one that dropped. And then here you have diaper change, crying. Notice the drop in cerebral SCO2. And then here, diaper change, reposition. It is sustained drop in renal SCO2. And that sustained drop seems to have an effect on uric acid, xanthine, and hypoxanthine, where there's an increase in the urine markers of hypoxia. And that ID number 6. This baby had a lot of crying episodes. Yeah, I think baby number 6 may have maybe somebody with intrauterine drug exposure. And you go, what does crying do? Crying here, it is crying. It looks like it does affect renal SGO2. In this crying event, there's drops in cerebral SGO2. This baby's pulse ox, this is what we can see in the machine. The pulse ox dropped to 58%. Notice how that also dropped the cerebral SGO2 as well as the renal SGO2. So when you see the pulse ox dropping, and you can see that it's accurate, it's not just because of movement artifact. No, that is also an effect on cerebral oxygenation as well as renal oxygenation. So this baby is crying a lot. The baby is repositioned a lot. Unfortunately, I don't have hypoxia marker data on that baby. But again, repositioning has an effect. Like this number 6, this is baby number 6. Was repositioned a lot because the baby was crying. I don't know if that was the nurse's intervention, trying to make the baby comfortable, but it does have an effect on cerebral SGO2. And the question is this effect harmful? Maybe a drop in renal O2s by 8%, a negative 8%, maybe that's nothing, right? I don't know. So what if the hypoxia markers went up? Maybe it doesn't change. I don't know. These are the things that we know this is happening, but we need some data to then say what is the cause. So if there's a drop in cerebral SaO2, which is what is NIRS, will that cause neuronal damage? So we need to measure. There's a way to measure neuronal damage. Okay, so that needs to be measured. But I guess I do have measures. I do have hypoxia markers on ID number 6. So on these babies, a lot of the procedures decreased O2 saturation in the brain by at least 6%. And we do see an increase in hypoxia markers of uric acid in the urine, xanthine, creatinine, and hypoxanthine. In this baby right here, that did have an increase in hypoxia markers. So what do we do? All right, these are things that we nurses do. What are we going to do? Let's look at the baby. These are tasks we have to do. First and foremost, we need to be able to assess pain, and everybody uses, I think, I know Loma Linda uses NPAS. I don't know what other people use. In my studies, I use this PIP profile, but notice that this pain assessment scales have behavioral components that are subjective, okay? And many of us know that a crying baby is not just crying because of pain, they could be crying because of other things. So to really assess pain, we need to develop better tools that are less subjective and the tools that we really be able to quantify that pain really exists and not use these scales that are helpful. That's all we have, like the facial expression, like the NPAS facial expression, that's good. The behavioral state, the vital sign changes. Unfortunately, when heart rate goes up and blood pressure goes up, all these are signs of pain, but they can also be signs of other things like hypovolemia, right? I mean, these are signs of other things. They're not specific to pain. So we need better pain assessment skills, but we need to use what we have. That's what we have. Now, for procedural pain, there's several non-pharmacological interventions. Kangaroo care is well documented to reduce signs of pain. I mean, we cannot ask the baby if they're in pain. All we can measure is signs of pain. Okay, so it seems to reduce signs of pain. I think for us, it's the implementation. This kangaroo care is difficult, requires a lot of, the parent first needs to be there, and they cannot be there for all the time that we're doing painful procedures. So this is our randomized controlled trials have shown this to be effective. Swaddling, tucking, massage, music therapy also have been shown, but it's not known how much, how long combination. So we need trials to know how often, how much, the swaddling, tucking, everybody needs to be taught how to do this. Massage, where to massage, for how long, how deep, we need to know that. What kind of music, what kind of sound. So all of those needs to be quantified and need to be clarified, all right? Breast milk, it's been shown to also be, to reduce signs of pain, but breastfeeding is better, but the mom is not always there. The pacifier is also effective. Acupuncture has been shown. I don't know if any one of you are using acupuncture in the NICU. Use of sweet solutions have been are also other interventions. Sensorial saturation. This is where they're doing multiple things. We're doing swaddling, tucking, giving music, massaging. This is a combination of multiple things are also shown. But again, these are the studies related to this are small. And so we need more prescriptive type of studies to say, okay, when you do it this way, this is the outcome, okay? And then use tools that will really quantify pain, that decreases the amount of subjectivity to our assessment. Now, one of my studies is on oral sucrose. I talk about this in this conference. Sucrose is sweeties, very effective in reducing the behavioral signs of pain. But a group from the UK, Rebecca Slater, showed that even though the behavioral signs of pain is reduced, the EEG signs of pain is still there. It did not reduce the EEG signs of pain. From the EEG study, the pain is still there. The baby still experiencing the pain. And the sweeties also did not decrease O2 consumption. Because remember, the problem here is ATP is being utilized as the pain is stimuli is being transmitted to the brain. And also, if really there's not enough pain, cortisol levels should drop, because when there's stress and pain, there's cortisol, right? And if sucrose is really reducing the pain, cortisol levels should drop. It did not decrease the library of plasma markers of pain. It also did not prevent development of remote hyperalgesia, which means, for example, in this study, they gave sucrose to a baby before giving vitamin K. And then for the next painful procedure, they looked and see if giving oral sucrose prevented or changed the response of the baby with the second type of painful procedure, this time of venipuncture. All right. And it seems to did not prevent the development of hyperalgesia, which means that if a baby got a vitamin K poke when they did venipuncture in a remote area, the baby's pain response is more. It's a bigger response to the second painful procedure in a remote area. It's very interesting. From my studies, oral sucrose increased plasma markers of ATP utilization. So from my study, it increased uric acid in plasma, it increases hypoxanthine in plasma, it increases xanthine levels in plasma. So instead of helping conserve ATP, in my study, it used ATP as evidenced by higher levels of these plasma markers. And then more concerningly, in a group in Canada, they did studies in mice where they saw that repeated exposure to sucrose in the first week of life, 10 times daily, which is essentially the amount of time our babies are hurt every day, before any needle prick compared to placebo, they have long-term alterations in white and gray matter volumes. That's really concerning. And then mice that received sucrose, they had poorer short-term memory in adulthood compared to control, which did not receive the sucrose. The combination of sucrose and needle prick did not protect against impairment in short-term memory. So I think that's concerning. There is a human study where they saw that if a baby, because of all these concerns, there's a study that showed that if we give just 0.1 ml or 24% sucrose, it's okay. And that the poor motor developmental attention scores in babies had to do with 10 doses per day. So basically the thing right now is to give them minimal dose, 0.1 ml, less than 10 doses. And that should help us not have the baby not have all this CNS developmental type of problem. The study that I had was published in Journal Pediatrics, showing that with the use of sucrose, this plasma marker went up. And then in some babies that did not even show any pain, allantoin levels, this is oxidative stress marker, went up. I did another study I just published in Journal Perinatology. If sucrose is bad or can increase ATP utilization, how about dextrose? It is also a sweet solution. And we just published this January 2020. And it showed that if we give oral dextrose, it also reduced signs of pain and did not increase plasma markers of ATP utilization and oxidative stress. There's a retrospective study from Stephen Miller's group where they said that there is that greater procedural pain and higher glucose. So now they're looking at glucose also related to poor neurodevelopmental outcomes. Now this is retrospective. They're just doing chart reviews and then looking at MRI. And they said that 8 ml per day of glucose exposure could be what's causing the poor neurodevelopmental outcome. And they said that the females with a higher number of invasive procedures and have higher, that receive more glucose, are the ones that are affected most. So there's a sex effect and gender effect also. Other data, this was reviewed by McPherson in 2020, there's considerable variation in practice, and we're looking at not just skin breaking procedures. This has to do with, for example, surgery. You need to give anesthesia. It's beneficial, prevents brain injury. And then sedation, there's a lot of this, the studies on sedation is still unclear. So there's a study looking at fentanyl. These are rapidly acting opioid agents with relatively short duration. Maybe that they're good for moderate painful procedures like intubation. Those are being studied. There's a randomized controlled trial looking at continuous midazolam infusion during mechanical ventilation. However, even though pain scores drop, there's hypotension that was seen and decreased cerebral blood flow velocity. This increase in severe IVH, in PVL, or death. So this is midazolam infusion for mechanical ventilation. Then in animal studies, it causes the brain, the neurons to die, neuroapoptosis, and have all kinds of functional deficits. There's also continuous opioid infusion with mixed results. It seems to prolong duration of mechanical ventilation, delayed tolerance in enteral feedings, there's tone abnormalities. The retrospective studies on opioids, the results are not as negative. Another one that they're looking at is something called dexmedetomidine, which is alpha-2 receptor agonist. And this inhibits the ascending pathway. Remember the pathway that goes from the spinal cord up to the brain. It inhibits that pathway, which may also decrease pain ascending pathway so that the pain stimulus does not reach the brain. So what do we do? I think this is where, as a nurse, when we come to the bedside, we have to find a way to get to know our baby. This baby has negative touch. This baby's fine. We have to find a way to know how the baby's response. And the previous nurse should tell us that, right? That should be documented. That should be given in report. Because there are babies that do fine with handling. There are babies that don't. We need to know who those babies that don't do fine handling is. We need to reduce painful procedures. We need to pay attention to the baby's cues and physiologic responses. Is cluster care the best way to care for premature infants? When we do one thing after the next, notice how there's a sustained reduction in some babies. Actually, in most of the babies in this pilot, there's a sustained reduction in cerebral SpO2, sustained reduction in renal SpO2. So when performing tissue damaging procedures, utilize your standard care. Use the minimally effective dose. So if you're using sucrose, less than 10 doses. If you're using glucose, less than 8 ml. And then these bundles, non-pharmacological bundles. And adjust care protocols to minimize stress related to handling. And again, participate in randomized controlled trials. This is really important for us. If we can't really know, we need evidence that will lead practice. Otherwise, it will just be hearsay, right? Otherwise, we will have inconsistent outcomes. So these research studies, if we can participate in them, that will be really helpful in helping move this area forward. And I think I'm done.
Thank you so much. I think
Yeah,
everybody was also really enjoying the review in the beginning of pathophysiology for ATP.
yeah. Yeah, let me know if you have any questions. I have all kinds of pictures. If you have questions, I'll be able to go over it again with you. I love physiology.
I have a question. Has there been a study that's compared two groups, maybe one group to be randomized to getting sucrose during heel stick and maybe another group to getting expressed breast milk?
That's a good question. So glucose and versus breast milk, expressive breast milk.
Yeah, like using breast milk instead for painful procedures.
Based on my memory, it seems like the sweeter solution seems to have the biggest effect in reducing the behavioral signs of pain. So if
Then,
it's glucose breast versus expressive breast milk,
so what about measuring the markers that you talked about on each group? I feel like it would be really interesting because I feel like we've already discovered so many benefits to breast milk and the anti-inflammatory processes.
right,
So I
right.
just wonder if we would see that reduction in those markers that you're talking about.
Yeah, I have not seen any studies on that. The study that I do have has to do with glucose versus sucrose. That's what I have. And for this study, what I did was we randomized babies to be control, which is the babies that I think I showed this data somewhere. Controlled dextrose or sucrose, because based on our study, sucrose increases ATP utilization. And my second study showed that dextrose does not. So I compared them over a 5-day period. They have life 3, 4, 5, 6, and 7 over days of life 3, 7. They randomized to either be control, where they do standard care, dextrose or sucrose. Now, control means in our institution, they're supposed to give sucrose. But unfortunately, no one in the control baby got sucrose. So this control group essentially become an untreated group.
Oh, wow.
I know. So and this is the hypoxanthine. Remember, ATP is degraded to hypoxanth to multiple steps, hypoxanthine to xanthinic acid. And in this, the one with the highest hypoxanthine is the sucrose group. The control group and dextrose group are here at are kind of the same. But then if you look at the xanthine, the babies that got nothing have the highest. And then the babies with sucrose also is similar to the babies who got no pain treatment. And the babies with sucrose have higher xanthine compared to babies with glucose. This is the glucose group or dextrose group. Then the uric acid, the babies with no pain treatment have the highest uric acid. And then the babies with sucrose and glucose are the same. Now, this could be a good thing, meaning that sucrose and glucose are equally effective in reducing ATP use, or it could be notice that the glucose is always the lowest. Yeah, dextrose is always the lowest. This is the dextrose is always the lowest. Then notice how sucrose is high in hypoxanthine, then starts dropping and then drops again with uric acid. What this could be because this uric acid could be because it's lower because it's being changed to another free radical called allantoin. Okay, so this may not be what it seems. But anyways, the sad part, like I said here, is we are not meaning for babies not to have anything, but it turned out, this is what's 2013. It was a long time ago. We just did all the measurements. But it just showed that those babies who did get nothing have the highest levels of uric acid, which is a hypoxia marker.
Mm-hmm.
So give something to the babies, whether it's sucrose or glucose. If it's sucrose, 0.1 ml, less than 10 times a day. If it's glucose, less than 8 ml per day. Those are the doses that are shown to not cause damage or neural damage. But yeah, this type of study needs to be looked at for breast milk, right? That absolutely. I've stayed away from breast milk because when doing a randomized controlled trial, the thing is, okay, so who's the breast milk? Not every mother has milk. Is this mother going to allow me to use another bank breast milk? If you're looking at inflammation, is there a difference between bank frozen milk versus the fresh milk. There's so many different variables that one has to think about before I go into this type of randomized controlled trial, but definitely is needed for sure.
Jackie's saying that the UK is actually advocating breast milk instead of using sucrose.
Absolutely, yeah. Yeah,
Mhm.
most of the people that emailed me are from the UK. They're the ones that are very interested in this. Yeah. Because sucrose is essentially fructose, right? When we give babies sucrose, sucrose is 50% fructose. All of us know that fructose is not good for you. Why are we giving it to our babies, right? That's sucrose. That's 50% fructose. Glucose is something that is, we give the babies glucose. We give it for hypoglycemia. Glucose is dextrose. Glucose is the same thing as dextrose. We give it for hypoglycemia. We give it in the line. The baby gets it. But sucrose is a totally different product that we're introducing to our baby. That's half fructose. So I think it's best if we really stay away from it.
Anyone else have some questions for Dr. Angeles
Can you call me Danilyn? Sure.
or Danilyn? I'm trying to be respectful.
Everyone in ICU, when I go, they call me Danilyn, so it's very strange. Any questions? Any other questions? I know I love physiology. I just have to introduce it. And I think it's good. But knowledge is power, right? Knowledge is power. The more you know.
It is. I think if nothing else, it makes you think twice when you go to grab that tube, that little purple or orange tube when your baby's crying and maybe they actually just want to be held.
Mm-hmm.
They're not in pain.
Right. Yeah.
We still see that sometimes.
Yeah, exactly. And then when you are giving the sucrose, realize it's a drug. You can't just keep squirting the amounts of sucrose into the mouth.
Exactly.
So 1 ml, less than 10 doses a day, that is what's shown to be not very good. That not be harmful at least. But again, there's no research on this. I've applied for a grant to study the long-term effect of sucrose administration, but I still have not gotten funded on that one. So I'm going to try again, but very few people are getting funded. The government has no money, so.
Yeah. Ruth was saying it's really good to be aware. Knowledge is power, just like you said. Kim is saying it's a lot of really great information. I like numbers and graphs, so the visual data also helps when I'm looking at interactions.
Yeah, I like pictures. I'm a very picture person. That's why
Me
I was going to go through all these paths, but I said, oh, this is too much now. So I just decided to skip that. But I can go over it if you guys want.
I think it is. I do see a lot of sucrose being used for withdrawal babies, and I'm like in between giving their morphine doses, and I'm just like, oh gosh, I don't think that's really going to help them.
So why are we not using breast milk for those? Again, fructose is something we don't even want to put in our own bodies, right?
Exactly.
Why are we giving fructose to babies? That's what sucrose is. It's 50% fructose, 50% glucose. And I think, Jackie, raising awareness, the nurse needs to be aware of how important they are as. The nurses need to be aware that it's not just handling. It's almost like when you're doing something to the baby, it has an effect. These normal things that we do has an effect on the brain, on the kidneys, on the gut. And it looks like the gut is hit, the mesenteric O2 saturation is hit more than, and the renal is drops more than the cerebral as a protective effect. But you still see that if you continue to touch and handle, and there's a more sustained drop in the cerebral ST2.
It makes sense. I was just thinking, of course, the mesenteric drops first and stays down longest because it's hierarchy of need, right? Like we'll protect our brain at any cost,
Absolutely.
at the cost of the gut, at the cost of the kidneys,
Right.
do anything to protect our brain, and then sustained hypoxia, whatever it may be, leads eventually down that path. But it's the body is relatively smart.
Right.
But I've heard Kathy talk about it, cluster care to death. Like cluster care is a great idea, but we can cluster care a baby to death. 75 different procedures, and then let's just get it all done.
Yeah.
It might take you 4 hours to recover from, but that's okay.
I was thinking that too, because I think we are moving towards that every 6 hours care, especially on our small babies. But how much can they actually tolerate if you're saving it all for that twice a shift? Like I have to do all these things. I think what's important and what we're seeing more of, which I love, is that do you really need those labs? And I loved hearing we're not weighing babies for the first 72 hours. You're going to use their birth weight. You're going to use their birth weight anyway to do all their dosing. Why are we weighing them every 24 hours? It doesn't tell us anything.
It doesn't.
So it's not changing our care. We're not changing our care of those babies. So I loved hearing that. I think we should move more towards those things.
I think we can do Q6-hour cares, and so we disrupt less and promote more sleep and all of those things. I think we just have to be cognizant of how well it's being tolerated, of grabbing a partner for that Q6-hour care so that they're feeling containment and those kind of things while we're doing it. Someone to attend to their developmental needs while we have to check off our tasks. Because regardless, we're going to have tasks, right? We can't escape them. But just shifting our focus to say, yes, I have to get these tasks done, but I'm going to do this, have you settle for a moment and then do the next one, right?
Exactly. Yeah.
Yeah. I'd like to echo what Shannon just said. I think that it's important. We all know about grace. We know we need to use that approach, and their space is a place that we're supposed to ask permission to enter and give them time to know that we're there and time to recover from what we're doing. So that's one way. How we do what we do is probably just as important, like Shannon was just saying. And I'd like to ask about a discussion or some thoughts about what age has to do with it. It's an article that was published by Hatfield et al. And it talks about the gestational age situation with the ascending and descending pathways. And I think that is really not very well understood. People just think all babies are able to modulate, and they can't until they're close to term. So I just wondered what you were thinking about that.
Yeah, okay. Sorry about this thing right here. So this is the ascending pathway. Let me get another color. So this is the ascending pathway. So let's say this is the heel stick. The action potential travels from the C fiber. Okay.
Right.
C fiber, and then you have other fibers called A beta. These are the myelinated fibers that has to do with touch, not non-pain touch. This has to do with pain.
Right.
In our babies, the touch pathway is immature. This pain pathway is the very mature. They're the ones that are, even though they're unmyelinated, those responses are the ones that reach the brain. Whereas the A beta myelinated fibers that has to do with touch are the ones that are immature. So which tells you that that's why in premature babies, the response to pain, the hemodynamic response is 10 times more, because the fibers that bring the pain to the brain are more mature in our premature baby compared to the fibers, the touch fibers, the mechanical fibers. And then this descending pathway right here that you're talking about, this inhibits the transmission. So if you have a normal, healthy descending pathway from the brain, it should inhibit this transmission. That is not developed in our premature babies. So all you have is go up here, not enough of this modulation and inhibition, which is present in adults and in older babies.
Yeah. Well, thank you. That explained it very well. And I just think that that piece of it needs to be thought about, that it's just a super pathway, right, and exploding everywhere. Yeah.
Exactly. And notice, and if you look at this, I'm going to erase this pain pathway. Where does it go? This is why the ATP, that's why there's hypoxemia or low O2 saturation. Where does it go? This pain pathway goes to the hypothalamus, there's an action potential there, goes to the cortex, goes to this limbic system. Remember, it has to do with the emotional action of pain, goes to this reticular formation. Again, these are all action potentials that cause the sodium to move into cells, but then the sodium potassium pump has to get out of the cells, causing ATP. This reticular formation has to do with awake. When you turn this on, the baby's awake. This is why pain disturbs sleep-wake cycle. And then it also turns on this periaqueductal gray, the auto synapse. So there's multiple synapses. All of them requires action potentials. All of them requires sodium movement and sodium removal, which requires ATP. And then this periaqueducal gray is what's in charge of this descending inhibitory pathway, but this pathway is not developed in our babies. What's developed is the C fiber, this C fiber that is developed. So the inhibition of pain, where you can stop this rise, is not developed in our premature babies.
Yeah, I think that this is such a good way to end our day, because we've learned so much about what we do at the bedside and how we can take our learning and do something different tomorrow. So I think that today's been such a wonderful day. You want to lead us out, Shannon? Thanks.
Yeah,
Jackie.
I'm here. Can you see me?
Yep.
I think that was such an amazing day of learning, as always. And again, I think today especially was very bedside focused. And Dr. Angeles, I think the way to wrap it up is to really say that this one interaction, every single interaction, if we're bringing it back to the one, every single interaction makes a difference somewhere to this baby, to this family, to this everything. And it's little tiny interactions. And I think that's just so important to remember as we go through our day, because again, we are task saturated. We have things to accomplish during the day. We have feeds we have to get in. We have labs that have to get drawn, diapers that have to get changed, weights that have to get done. And I think from that, we can take that every single time that we go into somebody's environment, some little baby who can't control that pain pathway or any of their other pathways for that matter, right? The pain pathway is the one we're talking about tonight, but like they have no self-regulation when they're super young. So I think considering every single interaction as an important something that will affect their life, I think that is how we have to take what we've learned and go into every interaction with that knowing that these little tiny things, so what can we do in our interactions to benefit our babies? I think that's how we take it out.
Absolutely.
Love it. Good job, Shannon. Thank you, Danilyn. Thank you, Sharon, Charla, all of our moderators for today. Just another great day. I can't echo it enough, that just this is all about that one thing. You've learned a lot, you've seen a lot. I hope you've been inspired, and it's really now up to you to take these little things and decide how does it change your practice on a day-to-day basis. So thank you again, Danilyn, and everyone. All right, you made it to the end. That was a jam-packed lecture. You started with the physiology and understanding what an amazing energy cost that pain and stress are. I just thought it was so interesting how Danilyn really made it just so clear how those neurons, as they fire together, that takes ATP, 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 and that's energy that our baby could be using for something else. So I just thought that was amazing. And then didn't you love just the way that she showed the actual painful experience and then how that actually can translate to the NIRS monitor and how that actually has that metabolic cost right at the cerebral cortex. So again, just fascinating stuff. And then what about that conversation around whether or not we should be using sweet solutions and which sweet solutions and the dose of those sweet solutions? It was just a jam-packed presentation. Just a huge shout out and thank you to our moderators for that session from our One Conference 2021. That was Sharon Bonifazi, we had Shannon Tinkler, and we had several other planning committee members there as well. It was a great day, and I'm just so glad to be able to bring these presentations back to you. They are still as relevant today as they were when we recorded them. And again, just a huge thank you to Danilyn Angeles, who just continues to be a huge mentor, a leader in our nursing research world, and just an amazing friend. So thank you to Danilyn for that as well. And if you like videos like this, I'll say it again, be sure that you hit hit the subscribe button. It tells YouTube that you like videos like this, and it helps us to rank and to be able to share more of these with more people. So if you need the resources, go ahead and click the link in the show notes below or scan the QR code right here on this screen, and you can get access to her handouts and links to some of her articles, as well as other resources that are related. So I hope that you enjoy that and don't miss this entire month series on pain, stress, and the neonatal brain. So with that, I hope you have a great week.